Good morning or afternoon for everybody. We're going to review a little bit on the following of abdominal viscera. The previous class we talked about abdominal structures, boundaries, lines, a little bit of some specific situations as the inguinal canal, having inguinal hernias. We talked a little bit about nerve distribution, considering the lumbar plexus in particular. But now the abdominal viscera holds some other interesting facts. Glands and some viscera that are important for you to understand and know because of the relationship with pathology that you'll see next term, the relationship with some other situations and differential diagnoses that you have to be aware of. So considering the abdominal cavity, we already know where the thoracic cavity is. So from the diaphragm all the way down to the lower pelvis, that's where the abdominal cavity is going to be related or referred to. And all of these structures are included in this a specific cavity or place in your body. From a frontal aspect, what you're going to see coming from the diaphragm and then down, you have your liver, you're going to have the stomach, but there's also places and anatomical situations, terminology that you have to be aware of. When you talk about the liver, you have to talk also about the hepatic flexure. When you talk about the spleen, you have to talk about the splenic flexure. You have to know how those two specific areas are related or what they have in common with the transverse colon, for example. And from the hepatic flexure, the ascending colon is coming, transverse colon, and then from the splenic flexure goes down the descending colon. The stomach, as you can see here, refer to all this area and open in a way to show you what how the wall is seen in a way. But the gastric chamber has also some specific parts that we're going to have to review in a little while. The omentum, which is this part of tissue that covers the front part of the abdominal cavity and makes a boundary with the posterior aspect of that abdominal wall, is going to be of importance as reference for example, the part of where the lower or the part of the curvature, the greater curvature of the stomach is related to the pancreas, and even to the part where intra-abdominal is considered, or intraperitoneal, and then the retroperitoneal is, and these structures are going to be very important. Perhaps this transverse visceral colon is going to be important in that reference. So an overview is about what you're going to have in the upper abdominal cavity, lower abdominal cavity, as upper half and lower half. The upper half, on the right side, you're going to have your liver, your gallbladder, you're going to have part of your stomach or gastric area, your pancreas just behind the stomach, and has to do with the first, second, and third part of the first part of the small intestine, which is called the duodenum. The third into the fourth part of the duodenum goes retroperitoneal, and then comes out again through a ligament, the ligament of Treats, and that ligament of Treats, that's where surgeons can follow all of this small gut going in and finding that ligament of Treats. That's where they say, okay, this is where the duodenum ends, the fourth part of the duodenum ends, and the jejunum starts. So, and that part is understood that it's also retroperitoneal going into the abdominal cavity. Blood supply, you're going to have two basic arteries, if you want to call it, for most of them, but all of the arteries are coming from the abdominal aorta. The celiac trunk is going to be the first one coming from the thoracic aorta, getting into the abdominal cavity, and the celiac trunk is a place where three specific arteries go out, and then the superior mesenteric artery, renal arteries that go specifically for the kidneys, the inferior mesenteric artery for other specific structures. And the venous cava, or the venous system, is through the inferior venous cava. The vena cava also is going to have two specific situations of interest, as the hepatic portal system, that has to do with only those organs that have to process some of the food, toxins, anything that has to go through the liver, they take it for here, for this area of the hepatic portal system. The venous system, or the systemic, also takes from any of these structures, but mainly the return directly to the inferior vena cava, goes from lower extremities and other areas. The liver has two fold to understand. One is an organ to produce something as excretory organ, and the other is the metabolic function, as has to convert glucose, works with amino acids for protein production, the bile production or formation, and some storage of minerals and iron in particular. Has 4 lobes, and typically the easiest way to understand is one left lobe, one right lobe. And there's a caudate lobe that's in the middle. Now, there's some other ligaments, as the left triangular and right triangular, and one falciform ligament for the kidney, for the liver. And there's the other one, the other lobe that was not mentioned, the quadrate lobe. So you have the left lobe, your right lobe, you have your caudate lobe, and you have the quadrate. So one is caudate, which is more into the inferior part, and this is a quadrate because of the shape. The gallbladder is very close to this quadrate lobe, so it's important to keep this in mind as where it's going to be located for this matter. There's some other impressions or areas where, for example, the kidney will go in that area, and the relationship of specifically the artery, the vein, and the system that allows for whatever's produced in the liver go into the gallbladder, and the relationship with the inferior venous cava, the vena cava there. So the inferior surface is important to see what structure do you have there. So you're going to have the hepatic arteries that you saw, the hepatic portal vein that's very near the superior end of the gallbladder, and you're going to have all those structures as the gallbladder, the inferior vena cava, the hepatic triad, the quadrate lobe, and the caudate lobe. You're going to have those hepatic arteries and the portal vein close to the gallbladder, but then you have to understand that how you call when the common hepatic duct joins a cystic duct, then they're going to form the common bile duct. So see it as, if you already know that a common bile duct, where it's located, then you have to understand, coming from a hepatic triad, this bile duct is going to be coming from hepatic ducts. You're going to have at least two, and you're going to have the cystic duct that goes from the gallbladder. So these two and this one form and join, and they're going to form a common bile duct. The hepatic artery, hepatic portal vein, and bile duct, all of these is going to be considered the hepatic triad. So a review again of all these structures, go over them in a simple way to understand. If you're looking at what surface, if this is the inferior surface, you're going to have a renal area, you're going to have a portal vein, you're going to have the cystic coming also from the gallbladder, and then you're going to have the artery that is not seen here or mentioned here, but it's this located right here. So you're going to have all those structures as the triad. As if you recall, lungs having those bronchopulmonary segments, well, the liver has also some segments. Not as relevant or important as in clinical matter as the lungs might be, but here the important thing is for us to understand that because each lobe will carry one of those triads, so they go there and they have to go, each one goes into each lobe, and they have exactly the same function, and they have the same type of cells for whatever purpose they have to do, either production and secretion of something, or the metabolic process of sugar, proteins, or any of the things that we just mentioned. So the blood supply is to understand that the liver is going to receive from two sources. One, for oxygenated blood for the whole circulation, which is done through the hepatic artery, and the hepatic vein delivering the deoxygenated blood from the small intestine containing nutrients. So this is good for the liver to do the metabolic process because of the nutrients. But this is has to be understood that it's deoxygenated blood. Hepatic artery gives oxygenated blood. And then that blood goes through the liver tissue, through the hepatic cells, and those hepatic cells, that's where the metabolic functions take place. Then once they've done everything here, either delivering the nutrients for the liver, not for the metabolic process, and for the metabolic processes per se, then they go out through the hepatic vein. And as you can see in that diagram, if I show you here, this is just a relationship of how they go from the small intestine getting into the liver and through the aorta or the hepatic artery into the liver, and how they they're gonna leave through just one single vein. So it's important that two ways going in with blood into the liver goes out through just one common vein. So the hepatic artery, where it comes from, like I said, it's one of the three arteries from celiac trunk. So the common hepatic artery is one, the gastric is another, splenic is another. But one of the celiac trunk's arteries is the common hepatic artery. From that it goes to a proper hepatic artery. From the proper hepatic artery divides into the right and left. The right hepatic artery is going to give the cystic artery for the gallbladder. And that's just a way of understanding. So in this image, you can see here the abdominal aorta. These first two arteries, we're going to see them later. But then you have the celiac trunk, and you have one left gastric, one splenic, olena, and then you have the hepatic. but this is, you have to understand that this is a common hepatic. Then the gastroduodenal and the right gastric is going to also come from here, and then following that, those two branches, then the proper hepatic goes into a right and left, and the right one is the one that's giving you the cystic artery for the gallbladder. The portal system is a very interesting system to allow all the nutrients and all those organs that are receiving blood and get nutrients from the small intestine or from any other area, getting out of the aorta, they go into the portal system, and only the portal system goes into the liver. Some parts of the organs might go through another way and not necessarily through the portal system, but all the abdominal organs, just for practical purposes, has to be understood that they have to go through this matter for the purpose of detoxification or metabolic processes that they need to have. So one of the things that are important for you to know is that the portal system, which is also called the hepatic portal vein, the hepatic portal vein is the formation or the union of the splenic vein and the superior mesenteric vein. So these two veins, the superior mesenteric vein and the splenic vein, they join and they're going to become and form what is called the hepatic portal vein. And those two veins carry from every single part of your abdominal area the blood needed for metabolic process, nutrients, detoxification, or anything. So the splenic vein basically is going to be taking from the spleen, the stomach, and pancreas. And the superior mesenteric vein, the rest of the organs, basically part of the stomach, small intestine, and everything that has to do with colon except the left side and the descending. That's another topic, but the ascending colon and the right half, transverse colon, small intestine, superior, and stomach are going to be for the superior mesenteric artery, the superior mesenteric vein. So here you can see a better description of this as how for the portal vein that's here, it's formed from the splenic vein coming here that crosses behind the stomach and joins the superior mesenteric vein, which is carrying everything from the small intestines, the ascending colon, and half of the right middle transverse colon. The left is going to go to another, like I said, we're not going to talk about it right now, but everything that has to do with jejunum, with ileum, and then the ascending colon and half of the transverse is going to go into this superior mesenteric vein. And again, the stomach, pancreas, and spleen, those are coming for the splenic vein. This word lienal is also for splenic. So the splenic vein and the superior mesenteric vein are going to form the portal vein here. So if you're more of a visual person, well, analyze this as where the stomach is. In this case, your stomach is, your spleen is on the other side, and how it crosses with the pancreas. So those will be from the splenic, and then coming from everything from the small intestines, the ascending colon, and having half of the transverse colon, they go for the superior mesenteric vein. They join at one point, and they form the hepatic portal vein. What the gallbladder does is store bile. So sometimes bile can be calcified or turn into some salts that will coalesce, and that coalition will give you some gallstones for this matter. So the important thing is that to understand that coming from the right and left hepatic duct, they're going to go and join the cystic duct and then form the common bile duct. Once this goes, it reaches the pancreas at the head of the pancreas and joins what is called the pancreatic duct. The pancreatic duct with a common bile duct, they're going to form one specific duct that is going to reach the second part of the duodenum at the ampulla of Vater. The ampulla of Vater has one specific sphincter, which is called the sphincter of Oddi. This sphincter of Oddi opens, closes, depending on what you're eating. It's more related with fatty meals, a lot of protein. That's when it's going to be more stimulated, the sphincter of Oddi to open, because of the massive amount or quantity of fat that you have to dissolve in some way to digest. So those are important things to understand. There's another accessory that goes also with a direct pancreatic duct going out, and that's through a sphincter that's called Santorini. The sphincter of Santorini just allows passage of pancreatic juices. Has nothing to do with a common bile duct. And it's also just a little bit on top, superior cephalad to the ampulla of Vater. The pancreas, we already reviewed the areas or the anatomical regions. So you have your pancreatic duct, you have your common bile duct, and then getting in to the sphincter of Oddi through the ampulla of Vater. So the pancreas, as you can see there, located exactly at the mesogastrium and a little bit on top of that in the epigastrium. So behind the stomach, but anything that is related with situation of the pancreas is going to give some problems to the gallbladder, to the stomach, to the digestive, for digestive purposes. Important thing also is to refer to a level, which is about L1 to L2 and L3. But between L1 and L3, that's where the pancreas is going to be located in that area. If you understand your belly button was going to be located, well, the pancreas is just going to be a little bit on top of it. I keep saying, if you know where your iliac crest is going to be L4, L5, your navel is going to be about that level, probably a little higher, L4. So just about that, just where my hand is located, just above my navel, that's where the pancreas is going to be located. Many people think it's up here. No, it's really down there. So the pancreas is going to receive blood supply from the pancreatic arteries, that this is directly from the splenic artery. The splenic artery is one of the branches of the celiac trunk. From the superior pancreatic duodenal artery, this is from the gastroduodenal artery, and the gastroduodenal artery comes directly from the hepatic artery. And the inferior pancreatic duodenal artery, this is from the superior mesenteric artery. So the pancreas is going to receive from three different sources. One that comes underneath from the what is called the superior mesenteric artery, the other coming from above from the gastroduodenal, which is the branch of the hepatic artery. As a matter of fact, the first branch of the hepatic artery, the common, is going to be the gastroduodenal, and the pancreatic arteries that come from the splenic artery that's off the celiac trunk. All the blood that goes from the pancreas out is going to go through that hepatic portal system, specifically through the splenic vein. So you can see here, again, another way, this is the pancreas. So you have your celiac trunk. You can see here your splenic artery, and all those short pancreatic arteries from the splenic artery goes into the pancreas. You have your first branch as the gastroduodenal, and the gastro goes to the stomach, duodenal goes down, but some branches go into the pancreas, and this is directly from the common hepatic, that is also from the celiac trunk. And then you're going to have from the superior mesenteric artery, the inferior gastroduodenal arteries for the pancreas too. A closer view of this for the celiac trunk. Remember that you're going to have your hepatic that goes to gastroduodenal, and then the right gastric. That's from the common hepatic. Then you're going to have your left gastric, and you're going to have your splenic coming from the celiac trunk. The veins, same thing. The pancreas is here. Pancreas is where my cursor is moving. I don't know if you see it, but the veins are the pancreatic veins that go into the splenic artery, the splenic vein, and the splenic vein goes to the portal vein. And that splenic joins the superior mesenteric vein. Microscopic view of the pancreas or pancreatic tissue. Some islet that you can see here, and the exocrine glands. See the difference from one to another. And the pancreatic islet, that's where the insulin, glucagon, and somatostatin hormones are produced. What raises or brings high blood sugar in a way? Well, the thing is that if you have, let's call it low blood sugar, like you didn't eat breakfast, then you have to, that's gonna have a special stimulation to the pancreas, and glucagon is going to be released. For this, pancreas is going to produce a little bit more glucagon just to stimulate breakdown into the liver. And that glycogen is transformed into glucose. By this, blood sugar is increased. If there's an increase of blood sugar in a way, this is going to promote into the pancreas the release of insulin. By this, insulin goes into the liver and transforms this glucose into glycogen for storage, or stimulates uptake from blood. So it'll go into tissue cells like muscle or kidneys, and that eventually that pattern also will lower blood sugar. So following to another organ, spleen is the largest of the lymphoid organs. So specific lymphoid cells like lymphocytes are either produced there, or in a way they're stored there in some way. So the spleen is posterior to the stomach and holds the left upper quadrant against the abdominal wall, and it has ribs 9, 10, and 11. So you start counting where you find 9, 10, 11, that's where your spleen will be. The other important thing is that celiac trunk is the main arterial blood supply for the organ, and the splenic veins will go out and they will join the superior mesenteric vein to form the hepatic portal vein. Another way of looking this again, so the splenic artery, which is here, is going all the way behind the stomach into the spleen, and some specific arteries that go to the pancreas, but also the splenic will give a posterior gastric artery. That's a very important thing to find out too. So the openings of through the diaphragm is going to be the cava or the cavas for T8, esophagus at T11, and aorta at T12, and psoas it'll be the psoas gap also at T12. So here the word please is missing, but at least to understand the cavas or the caval area as T8, then the esophagus at T10 and aorta T12, those are the three openings from the thoracic into the abdominal cavity. So the esophagus will receive blood supply from the thoracic aorta, the left gastric artery that's from the celiac trunk, and part of the phrenic artery. These first branches of the abdominal aorta going just crossing the abdomen, the diaphragm into the abdomen, those first are going to be the phrenic arteries, one left, one right. And typically this is just above where the celiac trunk is. And the venous blood supply, the blood return is going to go through the left gastric vein into the portal system. And well, you have to know that obviously the esophagus connects the oral cavity and the stomach. There's one specific part that goes through the diaphragm, and that's the cardias. The cardiac sphincter, that's the part where the esophagus ends and the stomach begins. The stomach starts at the cardiac region where the esophagus ends, and then just crossing at the level of the diaphragm. And then you have a small area of tissue that goes into the stomach, and then has three other parts that are very important. One is the superior part as fundus, the greater and lesser curvature, and then you're going to have the pyloric or the pylorus. And the pyloric sphincter, as the cardiac sphincter, helps to regulate the amount of food that goes in, doesn't allow to go up, or opens to go into the small intestine afterwards. And the stomach receives a lot of blood supply directly from the celiac trunk is going to be that left gastric artery. The right gastric artery comes from the common hepatic, which is typically from the common, not so much from the proper, because the first branch of the common hepatic is the gastroduodenal that goes to the gastric, to the stomach, and goes into the pancreas and to the duodenum. But then goes the right gastric, and then follows the proper hepatic artery. So also from the stomach is going to receive from the left gastrocleptoid, that's from the splenic, the right gastrocleptoid, that's from the gastroduodenal, that's part of also the hepatic, gastroduodenal and hepatic artery, and the short gastric, that's from the splenic. So you can understand that the stomach is going to receive directly from the celiac trunk, from the gastric artery, that's from the proper, the common hepatic as gastric, right gastric, and right gastrocleptoid, because the gastroduodenal is also giving you, and the left gastrocleptoid is coming from the splenic as well as the short gastric. So two from the short gastric, two from the splenic as the short gastric, and the left gastrocleptoid. Two from the common hepatic as being the right gastric, and the right gastrocleptoid that is also from the right gastroduodenal. And finally, the left gastric, which is completely directly from the celiac trunk. So review this image again, like I said, if you're visual, and think about the names of the arteries. If you understand the name of the arteries, it's going to be very simple for you to understand, okay, where do they come from? Or more appropriate, where are they going to? So there has to be easy. You have two lefts, you have two rights, and you have one short. The short and the left that comes from the splenic. The left gastric comes directly from the celiac trunk. And the right gastric and right gastroepiploid, these come from the common hepatic. Even this one, right gastroepiploid, besides coming from the common hepatic, comes from the right gastroduodenal. Muscle fibers are important to understand as a hollow organ or organ that can expand, and the amount of volume that they can hold is important to understand that those fibers have to have different directions. So it's just a matter of understanding that part. The cardiac sphincter is very close to where the fundus and the lesser curvature is, and then you're going to have the pyloric sphincter at the end of the stomach going into the superior aspect or the first part of the duodenum. The veins is going to be very similar to how their blood supply goes in, as the right and left gastric veins are going into the portal vein. The short gastric and left, that's from the splenic artery as arteries, they're going to go into the splenic vein. And the right gastroepiploid, that's part of the gastroduodenal artery, is going to go into the superior mesenteric vein. So same thing, portal vein, part of the directly through the splenic vein and the superior mesenteric vein are going to be related with the blood supply going back into the liver. So after the stomach, small intestines are threefold, as the duodenum, the jejunum, and the ileum. The ileocecal valve, way down here where the cecum is, that's where the end of the small intestine and the ascending colon begins. Something of relevance is that the jejunum measures, or the length is about 2.5 meters, which is about 9 feet, or a little bit less than 9 feet. And ileum is about probably 11 to 12 feet. So 2.5 meters for jejunum and 3.5 meters for the ileum. So in total, that's going to be 6 meters, which is about 18 feet. The duodenum receives blood supply from many arteries, and you can understand why, because it comes from the stomach, goes around the pancreas, receives those important ducts that they're coming from the liver, from the gallbladder, and the pancreas, and it's the center of everything. So it's one of those situations that are very active with nutrition and digestion. So all of these arteries are related with that part of the duodenum. And duodenum is very short, starts in the pylorus and just ends at the jejunum. On this left side of your screen, you can see how it starts. You see where the common bile duct, where the sphincter Oddi is supposed to be at the ampulla vater. Then the third part is down here, and then the fourth part goes behind the stomach and the pancreas, and this part in particular happens to be retroperitoneal. Then about this level, that's where the ligament of Treitz is placed, and from this point goes intraperitoneal or intra-abdominal. The jejunum is basically in the umbilical region, and the ileum goes from that area. There's no specific way to cut jejunum and ileum, but it just ends where the cecum is, and that's where the ascending colon. Your appendix is there. You're at the cecum area. That's where the appendix is. And the arteries that supply blood for these structures come directly from the superior mesenteric artery. The blood supply getting out of here to the liver goes through the superior mesenteric vein to the portal system. Remember, superior mesenteric vein joins the splenic vein and form the hepatic portal system. A cut or a division of your abdomen, talking more so from the duodenum and where it's going to join the duodenal jejunal junction. And like I said, about this level, that's where you're going to have your ligament of Treitz, T-R-E-I-T-Z, Treitz. And that's a very important landmark. As I said, recall retroperitoneal going into the intra-abdominal or intraperitoneal cavity. About the length of jejunum and then the ilium. Remember, jejunum is just about 2.5, ilium is larger, 3.5. For the colon, as large intestines, is going to start on the right iliac region where the cecum and the appendix is located. At that level, ascending, going up all the way to the hepatic flexure, that's where the liver is. And from that ascending colon going into the hepatic flexure goes transversely. That transverse colon goes all the way to the splenic area where the spleen is. That's the left colic area or flexure of the spleen. Then from that area goes down, descending colon, and then goes into the sigmoid colon down in the pelvis. You can see this line, oblique line, telling you or showing where sigmoid ends and rectum starts. Tissue is different, attachments is different, so there's a distinct situation where descending colon follows sigmoid colon, that's where the curvature is, and then finally gets into rectum. And one of the important things is that the rectum is in the area mid-sagittal. In the mid-sagittal plane, that's where you're going to have it. So you're going to have it right here. And finally, the anal canal. This is another view of this in an easier way, if you want to call it that way. You're going to have your, this specific fold or fibrous tissue is, identifies where the appendix is if surgeons can't find it, and it has a specific name. The ileocecal valve is right here, where I'm showing you where the ilium ends, and part of the ascending colon starts. The central part of it, is called the tinea. The tinea, omental tinea, it's a fibrous tissue that holds together in a way all of this structure to hold it in one position and allow also for transmission of signals as for peristalsis in a way, just to make some contraction. Also, there's some areas where you're going to find as called ostras and the semilunar folds. So these two words as ostras are the shape, normal shape of the colon, and the folds that you're going to see from the outside going in. Those are the divisions that the colon is going to be very specific for. And at one point where the sigmoid colon ends, that's where the rectum is going to begin. Another description of this, so again, just review it in your spare time and try to add always something else. Don't just memorize those words, but add something. For example, jejunum, tell me what's the length, where it starts, where it ends, if you happen to find that. What is the blood supply? Add always something. Repeat, even though you already know it. Do it again. Call the names of how these, let's call it little balls. You can call it there ostras. So you know they call ostras, and folds are in between. The tenia that follows the one part of the colon, and that's where the omentum is going to be placed. As you can see it here. And same thing here. Go again with looking at some specific structures as something that you might find interesting, and review it. So the arterial blood supply for the colon is going to be given by what side you're talking. You're talking about right side, from the ileocecal valve going into the ascending colon to the right colic angle where the hepatic flexure is, and part of the middle colic artery as for the right half of the transverse colon. So you're going to have these three specific arteries that come from the superior mesenteric artery. So you can learn it as what areas, talking about this diagram, what areas are you talking from your navel, if you're going to call it, all the jejunum, ilium, going as ascending colon, hepatic flexure, right half transverse colon, that's going to be superior mesenteric. Inferior mesenteric artery, and pardon me, and just get it the name. So ileocolic is going to go to the all of those areas inferior where the appendix and cecum is, and inferior ascending colon. But going the right colic artery like this, and middle colic artery like that. So just place your hands in a way to understand a little bit better. The inferior mesenteric goes to the left. So you're going to have the left colic artery, you're going to have the sigmoid artery, and the superior rectal artery. All of those are going to be given for the left half transverse colon, the descending colon, and even adding the splenic flexure of the colon going into the descending colon. That's going to be the left colic artery. Then the sigmoid artery for the sigmoid colon, and finally the superior rectal artery for the rectus. And everything of the blood supply for that goes from these structures, these organs, going to go directly to the portal system through the superior mesenteric vein and the inferior mesenteric vein. The inferior mesenteric vein, interesting, goes to the splenic vein. The superior mesenteric vein joins the splenic vein. So this is just another diagram for the arteries, and how the superior mesenteric artery goes as the ileocolic artery, the right colic artery, and the middle colic artery. All of these structures are being given blood supply from the superior mesenteric artery. So there's a comment here that showing that the middle colic artery branch entire transverse colon and descending colon. So is this an anomaly, incorrect, or just a variant? This is a diagram, a picture, a drawing. So probably some part of the middle colic artery can go this way, but also coming from the inferior mesenteric artery is going to give also left middle colic for this matter. And these are variants, as you can see in this, three different ways of showing. But the most important thing is that you can recall, as probably in normal stages, just about half of it to the right is going to be the superior mesenteric artery. Half to the left into the rectum is going to be the inferior mesenteric artery. So there you go. The left colic artery is going to have a superior left colic artery and an inferior left colic artery. All the branches of the sigmoid colon and the superior rectal artery coming from the inferior mesenteric artery. Pelvic arteries coming from the iliac, internal iliac, not so much the external iliac. We're not gonna review this one here. But later on, you're gonna find out the external iliac artery goes more for the abdominal wall. So the internal iliac artery is the one that's gonna give to all the organs. There are two divisions, one posterior, one anterior. The posterior, as you can imagine, goes to the back. So iliolumbar arteries, superior gluteal, and lateral sacral arteries are going to be included. For the anterior, just differs by gender because the two specific arteries there, considering the urethral, vaginal, or the inferior vesical artery for males, that's what you're going to have. So the anterior division goes as the umbilical artery, superior vesical artery, the obturator for females, the uterine and vaginal artery for males, the inferior vesical artery, the middle rectal artery, and the inferior pudendal artery. From this point on, the following classes are going to be included in some way. But just remember that the internal iliac artery and external iliac artery come directly from the common iliac artery. And the internal is going to give you posterior and anterior division. Posterior iliolumbar, lateral sacral, and superior gluteal artery. The inferior gluteal artery is part of the internal, but part of the anterior division. So same thing in other ways. Superior goes to midgut, the inferior goes to hindgut. Same thing with the veins. Everything's going to go finally to the portal system through the joining of the splenic and the superior mesenteric into the portal vein or the hepatoportal vein, and the inferior mesenteric vein goes directly into the splenic vein. Doesn't go into a joining situation as the portal anymore. Kidneys are important, as you can understand, because of the metabolic processes that they go through. Filter blood, get rid of all the waste, controls the amount of salt, sugar, whatever you need in your blood. So the important thing is that part of what you're going to see from a kidney standpoint are some structures that for the left kidney, you're going to have the spleen in front of you, you're going to have the stomach, pancreas, the left colic, flexure, jejunum. The right kidney is going to have in front of it liver, the right colic, flexure, duodenum. Posterior, you're going to have some specific structures like the quadratus lumbarum and diaphragm. Laterally, you're going to have the transverse abdominis. Medially, you're going to have the psoas major, and superior, the suprarenal gland. Probably here the two or three most important things, well, really two, is the psoas major and the quadratus lumbarum and diaphragm, because even though all of them can give some sites of referred pain, it's important to understand where they're located. So use your hand as a fist and place that as a kidney. So place it as behind you and say, okay, anterior, what structures do I have? Posterior, what do I have? And you know that's a quadratus lumbarum and part of the diaphragm. Laterally, if this is the left kidney, laterally, if this is the right kidney, you have your transverse abdominis. But then you're going to have something that's medial, that's the psoas. Remember that psoas is a major muscle or flexion of your hip. That's where the psoas is acting, and that's medial to the kidney. Superior, that kidney has a suprarenal gland. And this is a transverse cut, so you can see how the kidney is, how close is to the quadratus lumbarum, part of the diaphragm on top also, where the psoas is medially. So this is completely against those structures, and even to the colon. So anything that could be happening in the colon, like an abscess, or the other way around, some abscess or an infection to the kidney, can always go and jump to the other neighbor structure. So this is the level where you find it, where the aorta is. Typically it's about you're going to see some issues that one of them is higher than the other, and this is related because the left side is a little bit higher than the right because of the liver and the diaphragm. So liver and diaphragm pushes a little bit lower that right kidney versus the left one that remains just a little bit higher. So the left kidney is from T11 to L2, and right kidney is T12 to L3. The function, we're not going to go that much into that because in pathology and physiology you've seen something like this. But important thing to understand is this term as uriniferous tubule. And the tubule of the urine is given a specific in two ways. You're going to have one cortex and one medulla. Between the cortex and the medulla, that's where you're going to have all the filtration and finally the excretion of this urine into a papillary duct. The important thing is that most of the process is happening in the cortical side, and just the loop of Henle is in the medulla, and then finally the collecting tube goes from the cortex into the medulla to papillary duct. And all of this is what is formed a renal pyramid. So when you can see the shape of a pyramid, that's why it's called that way. There's going to be one structure that's very important, Bowman's capsule. And from Bowman's capsule, that's where the arterioles are going to be getting. One in, one out as the efferent and afferent arteriole. But this is blood. It's not going to be, it's blood that's going in and just moving, and just through Bowman's capsule, going out, filtrating that blood, and then going through some tubules as proximal and distal, convoluted tubules, loop of Henle, and that's where all those toxins or waste products are being collected finally. So here you have a pyramid, as a little while ago you saw it, and now a cross-section of a kidney, so you can see the renal pelvis as a major and minor calyces are here, and then you're going to have the pyramids, and how the pyramids are going to be divided through a cortical and one medullary area, and that's where the collection of urine is here in the pelvis, and finally getting it out through the ureter to the bladder. Another way of looking at this is how the renal papillary region is from those renal pyramids, another pyramid, and all of those pyramids have a cortical area and medullary area where the loop of Henle is. The tubules are coming out, and then they finally drop those drops of urine into the calyces minor and forming into the major, from a minor to a major, and finally through the renal pelvis, and from that point, it's not collected there, but it just goes through there, the ureter, and finally to the bladder. The suprarenal glands, as the name goes, they're placed above the kidneys. The suprarenal glands are basically the production of some very, very important hormones as cortisol, aldosterone, corticosterone, estrogens, progesterone. All of these are produced, and probably in the medulla, that's from the cortical region. The medullary region is for epinephrine and norepinephrine, and this has to do with stress, with control of your blood pressure. So this is, these are glands that are located on each one of the kidneys. Their division is as a cortical or cortex and medullary area, and this is important for you to remember, because when you go into pathology, this is something that you're going to be looking at. Blood supply for the suprarenal glands are important because one of them comes from the inferior phrenic artery. So the superior suprarenal goes off of the inferior phrenic artery, and then you have a middle suprarenal that comes directly from the aorta, and one inferior suprarenal that comes from the renal artery. Suprarenal vein is going to go out of the kidney. Important things for you as a clinician to always understand: you're going to have referred pain. So kidneys and ureters probably going to give you pain either way in the area of the renal fossa that is called, and most of the times they're going to be a referred pain into the inguinal region, into the scrotum even. So that's a very typical referred pain for the kidney and ureter. Gallbladder and liver typically goes to the right shoulder and the scapular area. When you take a deep breath, typically it's going to be cut because of something that's happening at the liver and gallbladder. Pancreas has a very distinct type of pain to left shoulder, mid-back, but typically goes directly like something is stabbing you from front to back, and that's very typical for pancreas. The stomach and duodenum could have a little bit more discrete and different ways, like a more generalized and mid abdomen, or probably can go to the either right shoulder, upper traps, lower thoracic. It's a little bit more diverse for stomach and duodenum. Chronic pain is important, but here if we're talking about the abdominal cavity, think about 14% goes referred pain in that area, where visceral is going to be 18%. So it has to do a lot of problem that has to do with pain in a way, much more than, well, except osteoarthritis, that's going to be 32%, and migraine is going to be 14%, and or headache in a big population, 16%. But visceral, if you're talking about abdominal, is 18%. So it's important. Review this chart, map, as what areas do you think it's more possible to have some pain, and consider, is this pain coming from this area or is something referred from another? And this is the importance of interpreting this map. If you touch your area of your below your neck, well, think about lungs, diaphragm, that's going to be on the right side, more so liver, gallbladder a little bit on the side of the right shoulder. Spleen, I don't see it here, but spleen typically goes to the left shoulder. It's very typical for the left shoulder for spleen. A review of abdominal arteries. So you can see that the inferior phrenic is just at the level of the aortic hiatus, where the entrance of the abdominal aorta coming from the thoracic through the opening in the diaphragm, that's where it's going to be. So you're going to have that inferior phrenic artery, and the inferior phrenic artery is giving you one to the suprarenal artery. Then it's going to be the celiac trunk. Then you're going to have the superior mesenteric artery with just about probably a centimeter inferior to that, both of the renal arteries, and one is going to give the inferior suprarenal artery too. Then you're going to have the ones that are to gonads, that's testicular or ovarian, and then you're going to have some lumbar arteries, the second, third, and fourth. Between the second and more close to the third, that's where the inferior mesenteric artery is going to be. And then where the fourth lumbar artery is, that where you're going to have a medial sacral, but then you're going to have the iliac arteries and the bifurcation of the iliac arteries and the common iliac artery, and then from that is going to be the internal and external. The levels are important as understanding what side are you talking about for referred pain to the back. Aneurysms are very typical to have and deliver some pain that is going to be referred to the back or even to the front, but the level is important as understanding. T12 is going to be the celiac trunk, and like I said, just about one level below is going to be the superior mesenteric. At the same level, the suprarenal, or just one level below the renal, is going to be the testicular ovarian. Just below the renals, the inferior mesenteric is about L3. So the common iliac arteries are going to be about L4, L5. The other important thing about L4, L5 is the level of the iliac crest. So if you know the iliac crest is L4, L5, and then you add also common iliac arteries, then you start understanding much more anatomy and some pain that you might have. Review these diagrams for your own purpose of trying to make up what arteries go to what structures coming from the celiac trunk, the superior mesenteric and the inferior mesenteric arteries. The celiac trunk, like I said, the left gastric that gives esophageal artery, and the left that goes directly to the stomach, the splenic arteries that get or give the pancreatic arteries, one short gastric, and you also have the gastroepiploic artery coming from the splenic. The common hepatic is going to give the first gastroduodenal and the right gastroepiploic artery, but then also a supraduodenal and pancreaticoduodenal. Then is the right gastric artery, still from the common hepatic. Then comes the proper hepatic, and the proper hepatic goes one right, one left hepatic. The right one is the one that gives you the cystic artery for the gallbladder. So here's where the structures that are receiving blood supply from these specific arteries. So just connect, for example, this one, try to make a point that you understand by the names of those arteries, where they go. The other way to do it is leave liver, gallbladder, duodenum, lesser curvature, and remove, for this matter, remove all of these structures. So whatever you want to do, it's fine, but try to make some connections here. The superior mesenteric artery, again, the names of the arteries and what structures they're going to give blood supply. Same with the inferior mesenteric artery, and the common iliac artery as external iliac artery, internal iliac artery, and external iliac artery. Remember that we talked a little while ago, the external iliac artery, we're not going to talk about it, but, well, here it mentions about the deep circumflex and the inferior epigastric artery to abdominal wall. And that external iliac artery is going to become the femoral artery when it passes deep to the inguinal ligament, or inguinal canal in this matter. So this is just a representation of how you see in the lower pelvis, how you see the finding of the abdominal aorta, the right common iliac artery, the external and the internal iliac artery. The inferior vena cava, understand that all system and the systemic veins will drain into this. So anything that comes that doesn't have to do with some nutrients, with some metabolic processes, they do not go to the hepatic portal system. They go directly to the inferior vena cava. So probably the suprarenal vein, L1, renal vein, the testicular ovarian vein, they go directly into the inferior vena cava. So we'll leave it here, and the following class will review more on the part of the lower pelvis, perineum, including reproductive systems. So thank you so much.